welcome to all who are joining. This is another of our research methods and secondary data analysis webinars, and we are delighted that you have connected with us today. As you know from the email information, these webinars, this series is co-sponsored by the Deep South RCMAR, the Resource Center for Minority Aging Research, the CCTS, the Center for Outcomes and Effectiveness, or CCTS is actually Center for Clinical and Translational Science. The CORE is the Center for Outcomes and Effectiveness, Research and Education, and the UAB MHRC, the Minority Health and Health Disparities Research Center. So with that, I will turn it over to Dr. Rob Weech-Maldonado, who will introduce our speaker today.
Yes, hi everyone, welcome. It's actually a pleasure for me to introduce today's speaker, Dr. Virginia Howard. She has been collaborating with me in the analysis core of the RCMAR, which is the Resource Center on Minority Aging Research. And so I have enjoyed working with her for quite some time now. And of course, she's a great mentor for the RCMAR scientists. So, but more specifically, Dr. Howard is a Distinguished Professor in Epidemiology in the School of Public Health. She's a stroke epidemiologist with over 30 years of experience doing clinical trials, longitudinal cohort studies with a focus on stroke, stroke risk factors, cognitive functioning, and health disparities. And she's a very prolific writer, as you can see, over 350 publications with an H index of 86. A lot of you may know her through her involvement. She's one of the lead epidemiologists with the Regards project, and which is funded through NINDS and NIA, and actually more recently now she is Regards PI of the Collaborative Cohort of Cohorts for COVID-19 research, C4R, and actually she's going to be talking to us about that project. So it is with great pleasure that we have Dr. Howard. So Virginia, all yours.
Okay, thank you so much. I'm so glad to have this opportunity to share this with you. And the timing could not be better for talking about this, as I will share with you more, at the end of the study, at the end of my presentation today. And I think that I'll probably try to go through the slides, maybe a little bit fast, but I want you to make some notes or save in the chat some of the questions if you need some more information on. This is an introduction to the C4R. And so I am using the C4R slides that they have given us as, kind of give an overview of what is C4R, and then I can perhaps answer some of your questions or direct you to someone else who can help with that. And so as Rob said, it's C4R stands for Collaborative Cohort of Cohorts with a focus on COVID-19 research. And this is primarily funded by NHLBI with additional funding from NINDS as well as aging. And this comes through Columbia University with Elizabeth Olsner as the contact PI and Graham Barr is the other multiple PI in this. And these slides were prepared as of the end of September, so very, very current. So as you can imagine, there's a great need, for observational studies of COVID-19. And based on recent data that CDC has compiled as far as the cause of death, here COVID-19 for 2020 is the third leading cause of death. And so you can imagine that even tabulating the causes of death over the 2020 period has been rather challenging. Based on the how fast everything happened and getting people their evaluations and coding of death certificates. So there's a great need to study this, very, very much so. So this was designed to support really strong observational studies of COVID-19 in US adult populations. There are some biases, as we all know about in observational studies, such as misclassification, confounding, selection bias, and collider bias and recall bias. Interesting, I didn't know a lot about collider bias, but that's kind of a big thing in some of the COVID research that's been done, because a lot of the reports that we've seen are based on potential biases in who gets tested for COVID, where the information comes from. And so the recommendation is to design your study up front so that you have a more appropriate sampling strategies for your research question. So the C4R study design was to look at general population samples that already exist and to get ascertainment of COVID-19 within those samples and do harmonization of the data that already exists, because there's extensive pre-pandemic phenotyping, all kinds of data already collected in these cohorts. So the C4R was really designed to minimize these biases in observational studies. And of course, some of these studies also have some of their own individual biases, but as a group, we're able to kind of come together to minimize these inherent biases. So these are the cohort studies that are in the C4R. Primarily, they are cohorts that are funded by NHLBI. And so their main focus has been on heart outcomes. There's also lung outcomes, and then there's the brain outcomes. And that's where regards is in. And there's another stroke study called NOMAS. And so what is shown over here are the cohorts and the target numbers to be included from each of these cohorts. And if you want some more information about it, what is a cohort that you might not be familiar with, you all may be familiar with the Cardia study because that's based here at UAB, and also the Spiromic study. We're also a site here at UAB for this study. And so within the current numbers of each cohort was able to identify, or asked to identify, who could they get from their study, who was still alive, who was still active, who did they think they could potentially enroll. And it ended up being about 53,000 participants. That was the target inclusion in the C4R. This shows the distribution across the United States of where the participants are, the field centers, and the coordinating centers. So the dots kind of represent where the participants live. So all over the continental US. Don't believe there's any in Alaska, in Hawaii. The large dots are, the large circles are coordinating centers, and the smaller ones are field centers. And so that's where participants also live. And so like if you have a field center, for example, for the ERIC and the Cardia, they have, ERIC has a site in Jackson, Mississippi. There's a Hispanic populations here in California, and the coordinating centers up here in Columbia, the overall C4R coordinating center. So a good representation. So there's potentially someone in every state, but larger numbers. And this is primarily related to regards, because regards is more national than some of the other studies. And this is the distribution of the target 53,000. So the expected enrollment in C4R is 24% Black adults, and 2% Asian, 5% American Indian, and 21% Latino, and 47% white. So an overall good representation, again, based on the race ethnicity of the cohorts that are included. I know you not going to be able to read this slide, but this is looking at all the cohorts and when they started. And so there's already over 100,000, over 1 million person years of follow-up. And so many of these cohorts already have multiple measures of like chest x-rays, biomarkers, omics, things that they collected at clinic visits, at in-home visits. And then a lot of these cohorts already were funded to do visits anyway in the middle of the pandemic. And so some of them had to maybe stop for a little while and then get going again. And some have ones planned for the future. And so here, this is really amazing to me that 78% were already scheduled to have an exam during the pandemic, whereas only 22% did not have one scheduled, did not have one already funded. So this C4R is taking advantage of what was already in place to just add some things onto here. And just to give this to you in perspective, this is starting at, I'm having a hard time even reading it so small, 1971. So the cohort that started in 1971 was the Framingham cohort. So that's the first one up here. But so Eric, for example, started their first home visit in 1987. And it just shows how many measurements they have, prior to the pandemic. And then these are the blue are showing what's continued, what is funded to continue, after the pandemic. So that's what goes through. So it's really nice that this was already set up to get information that could be utilized. Another one that is hard to read, but this is very exciting, and I'll give you at the end of the talk a link to the website so where you can look at this in more depth and look at it. And so this is the types of data that are available pre-pandemic period. As I mentioned, some of these studies started many, many years ago. So they collected a lot of this, and this is from 2000. This is only from 2010. Because we didn't think we want to go back a lot further, to get at those for the pre-pandemic. So here, for example, in terms of information on the gut microbiome is about 9,000 participants we have these data on. We have a methylation from genetic data on almost 19,000 participants, ECG monitoring on 4,000. About 17,000 had some, I can't even say the word, actimetry, some sleep studies, almost 12,000, a lot of neurocognitive assessments done in different ways, some done over the telephone, some done in person, and 8,000 had brain MRIs. And so that's interesting, of course, to look at the post. So look at people who had COVID, who didn't have COVID, and look at some pre and post MRI, ECG data, CT information, and some lung. There's a lot of lung studies information, and hand grip and timed walk. So these are kind of categorized in neurologic, cardiac, and imaging, things like that. And this is a comparison of another study called TopMed, and TopMed is funded by NIH, and it's a whole genome sequencing project. And so what this just shows is already some of the harmonization that's taken place. So of the 14 cohorts, 10 are part of TopMed, and these 4 are not. So what this means is that there's already harmonization and some comparisons and kind of matching up with the omics. So if you're interested in some of the GWAS and other information, these groups have a lot of that information. The key research questions that were written into the grant. So the way this worked was C4R pulled the cohorts together. There was actually a call for cohorts to be included in this project. So NHLBI put out a call that says we want to do research. We want to create a cohort of cohorts. And so please apply. So a lot of cohorts, put their name in the hat, and, Regards did, and Mesa and Eric and all these to be chosen, to be selected, and it was really to look at, what are the major determinants of incidence and then severity of COVID, and then look for disparities across the US population. And the advantage, of course, that we had in going through this and all the cohorts was the pre-COVID measures, then moving to the COVID state, and then following post-COVID. So we would have people who didn't get COVID and people who did, and then look at some other relationships following those who did and did not get COVID, all kinds of potential measurements on that. And then what were the long-term complications of having an infection and the severity of it over time, short-term as well as long-term. And then hopefully to follow long-term. Right now, we're only funded until 2022. I think it's the spring of 2022. But how has the COVID pandemic perhaps altered to all of trajectories of health, not just in people who got COVID, but people who didn't, in terms of their maybe going to the doctor for a screening test or their access to medications and things like that. So it's really interesting to look at those who did and did not get COVID, and really to look at all of the heart, lung, and blood and neurological and social determinant variables that may have impacted all of these questions related to that. This shows the data collection that we are doing now in C4R that we were funded to do. There were standardized protocols that all of us contributed to, and we came up with kind of a required questions to ask and then some optional questions to ask, because some of the cohorts started asking COVID-related questions earlier than the C4R funding period started. The C4R funding period actually didn't start until October of 2020. So some of the cohorts were actually asking these questions in March. When it first came out, they were really on the ball. So we have a wave 1 questionnaire and a wave 2 questionnaire. So wave 1 questionnaire is kind of simple questions about, do you think you had COVID? When did you have it? Did you go to the hospital? And then wave 2 questionnaire is more about the same questions again, but did you get a vaccine? And were you hospitalized? And then post-COVID recovery type questions and symptoms that they had and some things like that. And then we also have a serosurvey that's dried blood spots. And then we're doing events adjudication. So these are the funded parts of the C4R, these 4 units right here, the wave 1 questionnaire, wave 2, the serosurvey, and events adjudication. And the timeline for doing this is here by cohorts. And so here we see that the COPD gene, well, they started their work early. And this is blue here is the wave 1 questionnaire. The black is the wave 2 questionnaire. The serosurvey that stands for dried blood spots is the, I guess that's kind of a brown beige color there. And then events adjudication is kind of ongoing when someone reports a hospitalization. And so MESA had already started. And the advantage of some of these cohorts that already started in is then they could use their experience to help guide us in what type of questions to ask and what not to do in terms of what should be required. And so it's great to have these both the wave 1 and the wave 2 that started again. And, think about what was going on with COVID and the different variants, so the Delta variant. So we're asking different things. So we have some time. So the people who got asked these questions the first time in wave 1 will get it asked again in wave 2. And so we'll have some more information about it. So the data collection principles were really to standardize this as much as possible across the 14 cohorts. And let me tell you, that has really been an interesting process. It's really worked well because everybody wants it to work, but sometimes it's challenging because of time and budgets. Everybody's cohort has already their own budget that was already preset, and then there's only so much money that C4R gives you to add to it. And so we want to be adaptable to the extent that the cohorts can be adaptable with their participants, and then to harmonize the types of data that we have so that we can pool the data and write the papers together for that. So this just is showing some of the types of questions that we're asking about. So we ask if you got tested, do you think you got COVID, were you hospitalized, what were your symptoms, some questions about recovery, like do you think you've recovered? And we it's kind of up to them what they think recovery means. And were you reinfected? What about your contacts? Did you know anybody who had COVID or perhaps died from COVID? Other vaccines. We have some information that we ask about impact on behavior in terms of behavior changes that you might have had during the COVID pandemic, sleep habits, memory loss. And this slide also shows where the questions came from. Whenever possible, we tried to use common data elements, the Phoenix toolkit, and standardize that NHANES and PROMIS and other standardized testing. Again, that was to kind of match it up with the pre-COVID tests that the cohorts had done, as well as to make it be able to be pooled across. So anxiety, fatigue, and there's a brief resilience scale. And then because this questionnaire was so long, there were some optional questions that people really wanted, but everybody realized, for the average participant, you not want to stay on the phone for 45 minutes. And so we had to take that into account. And then it was also interesting that the different cohorts use different, of course, ways to administer the questionnaire, because as I mentioned before, some cohorts already had planned visits in clinic visits that they were going to do. And so they actually gave them to them while they were in the clinic if they were doing that. Then of course, COVID switched people sometimes to maybe telemedicine type things. And so we did them through telephone or through the internet, mail questionnaire. Regards did a booklet type questionnaire. And then there were others that could use the web portal depending on the age of the cohort and whether they used email. So lots of different mechanisms, but a little bit different format if you're doing it in a booklet, self-administered versus asking somebody in terms of how the skip patterns go, because there's a whole series of questions that you skip out of if you say, no, I didn't have COVID. And so there's a lot of simplicity with that that's easier on the telephone. This just shows the completion of the 53,000 that were targeted. We have about 85% have been completed as of the end of August. So that's really tremendous. And this just shows the distribution of the target. It's by age, race, ethnicity, and sex. And so we had some idea of the cohorts characteristics, the demographics of it. So we targeted, we knew that we didn't have a lot in the 18 to 30 year range. And so this is just showing what our target was and what we've gotten so far. There's still a few more out there. So the largest number expected was really 65 and older. And we still have a good number across the race ethnicity groups, and about 64% are 65 and older. About 8%, just based on self-report, said they had had COVID. And that's pretty reasonable in this population with this age group, and what they would have done to prevent them being exposed to that. So that seems to be in line with our expectations. And of those, 38% of those who self-reported COVID, 38% were Hispanic and Latino, and 14% were American Indian, Alaska Native. And the reports on potential hospitalizations for to be adjudicated as were these serious COVID hospitalizations, we've got a report of about 1,100, and about 1,000 of these are within our scope that we are currently collecting medical records and reviewing these, and they've been reported, as either death or hospitalization. And again, these were recognized and reported through the questionnaire. So these were either wave 1 or wave 2, trying to match up on all of these. And so what we're looking at now is in the medical records, we've got a great team of people at Columbia, as well as some of the individual cohorts, are going through medical records. And some, of course, are electronic medical records. Some are from, as in the case of Regards, from all over the country, and trying to get through the medical records to find out what was the severity of the illness, and different measures. And we've tried to standardize some of those assessments to look at also the complications of that. So we are just in the very, very early stages of that, very complex, because this is not your typical way that the cohorts review events. Say, for example, many of the cohorts are looking at MIs or heart failure as their outcome, or stroke. And so they have really significant detailed protocols to define things. And so here it's a little bit different, because if you're looking at COVID in line with all these other things that you'd like to look at too. So we're stay tuned for that. We're still working on that. This is really very exciting that we're doing these dried blood spots. And so what all the cohorts are doing is they're asking the participants in some fashion, either usually by telephone, I think is how that works, or they may be doing it in the clinic, because we've just started that this year. So we mail them a kit to do their to prick their finger, and you just put it on this card. And so it's a simple finger prick, and they fill in these circles here with it, and it is not a lot of blood. And even if they can't fill in all 5 circles, they can still do the testing. And so the kit is mailed to them with the simple instructions and a lot of pictures on how to do this. And then it's mailed back to the University of Vermont, where they process it and then send it off to this lab in New York. And they do the blood testing for the antibodies. Now they're going to be doing some other work on that too, but this is just a test to see, to give some results back to the participant. And so of the 10,000 that they've returned so far, which is only 40% of what they get. And keep in mind that these are people who had the vaccine, haven't had the vaccine, gotten one of the vaccines if they were the double. And we're just now, of course, getting into people who may have had their booster shot. So the results are very, very interesting. So 78% did have evidence of antibodies, and 12% did not, and 5% were unable to be examined. And I just thought you might be interested in what we're allowed to tell the participants, because this is not a clinical test. It's done for research. We can't tell them a whole lot of information. And so what we do is tell them what it means, and if they need to know more, then they can maybe discuss it with their doctor. But so if it's a negative test, all it means is that we didn't find antibodies, and we don't know. We can't say that your antibodies are gone, that you never had them, but all we can just say is that as of right now, when you had your test done, it was negative. And if it was positive, that we found the antibodies is what we can tell people. So we don't know if it means that you were vaccinated, and we're not, even though we have data on their vaccination, we're not trying to link it back to that again, because that's more complex. We're trying to get at the timing of everything. And it could be from a different type of coronavirus as well. So we're just saying you had antibodies, in your system. And then unfortunately, there may be sometimes that it could not be interpreted. And in regards, we're giving people a thank you incentive gift card for completing the dried blood spots. They get this result, and they also get a gift card for completing the booklet with the questionnaires, because it's a little bit longer than their normal work. This is showing some of the results from the Wave 1 questionnaire. And so this was asking about recovery. And so it's just saying that of those, and this doesn't give me the total in here that it's from, but so of the people who had COVID, 73% of them say they have fully recovered. As the question is asked, have you recovered? And it's up to them to determine what that means. So if they still have fatigue, or if they still have, and of course we have dates of when they have it. So this is when, between less than 2 weeks from when they had it, only 26% say that they had recovered. And so the timing you can see down here. And there are symptoms that remain. And so we asked them about the symptoms associated with the COVID. We also asked them about symptoms after COVID. And so a lot of people, 87% had, of course, persistent fatigue, shortness of breath, cough, and chest pain. And the Wave 2 questionnaire asked for longer information about the time period that we ask them, because we also have timing of when they got it. So it could have been in the spring, and we're asking them questions now that they can recall about when they had it and how long they still have symptoms. So the way that it works as far as kind of running things, NHLBI provides the resources and the funding. We're connected with this Connects group that kind of helps to coordinate all the data management and facilitation. And we have an executive committee and a cohort coordinating committee that each cohort has a representative on as far as voting on things. There's a lot of subcommittees. We have a lot of Zoom conference calls, a lot of discussion, and it's still ongoing. Even though we're in process, we still are talking about writing papers and doing things with all the data. So there's a lot of committee works. And this is just showing how it all feeds into harmonization. So we have people, on every committee, so that the burden is not too much to be on a committee. If we have a call every other week for the social determinants of health committee, and the neurocognitive meeting is like, say, it's every other week as well. So it just depends on the burden for that. And this is in one of the most important slides, is to learn more about it, is this C4R website, www.c4r-nih.org. And they've recently just updated. And so for the public facing website, it's been improved, and it's easy to find things. This is also showing you the study design paper. And in the earlier slide, I gave you a link to that. So this is a preprint, and it's in the revise and resubmit to have gone through peer review. So it was published, I think back in March, but it's going through a peer review process to fix it up a little bit. But that's very informative, for some more details for this. And then this is the analysis commons. And so it's in the biodata catalyst, and it's modeled after the CHARGE study, a long study, and with NHLBI and all that. And so about sharing data. So the data from all of the cohorts, the common data from C4R have been deposited in here so that people have the age, the basic demographics there, and you can get access to the data when you have an approved manuscript proposal. And this is where you actually get the data and do the analysis, on this Commons folder. That's where they have all that. So you get permission to access that once you have an approved manuscript proposal. And speaking of manuscript proposals, these are some of the manuscripts that are in the works, and some are still under review. So here's a sickle cell trait and the risk of severe COVID, looking at this in the African Americans within all these 14 cohorts, looking at the infection and cognitive function, outcome of cognitive function, D-dimer, metals and smoking, adiposity, and there's also some methods papers in here. And so on the website, there's also a listing of all the papers that are in process. And as I mentioned at the beginning, just yesterday, so the timing could not have been better. Just yesterday, they released a call for papers. And so, like I showed you, there are already some proposals approved or in development. You can go to the website and see what there are. But as you can imagine, there is an infinite number of opportunities across all kinds of domains, blood samples and infection and health behaviors and social isolation. There's just so many things. And so if you go to this website, it will give you what data are available. It will describe the analysis commons, where the analyses actually take place. And there's awards and training opportunities and the policies and procedures, and then the manuscript proposal form. But speaking of the awards, they really, really want early career people, and they're focusing on underrepresented minorities as well as women. And they have 10 mini awards of $5,000. And I just heard on a call this morning, they said they're really, really pushing this, and they want to have them, at least 7 of them, awarded by the end of November. And so I really encourage you to think about this, and because they will work with you and facilitate, and I can help you, get up with somebody who it may be help with your topic of interest or things like that. So this is the timing is good. So you got a head start over everybody else, because they just sent this out to the C4R people yesterday, which is over 100 people, but that's mainly the leaders of the cohorts and stuff. So you have an advantage over getting that. Now, they are trying to do some more work, and there is funding that you might have heard about called Recover. And it is it's funding from NIH, and a lot of the institutes contribute to that. And it's researching COVID to enhance recovery. And they put out a press release on this on September 15th, but that was primarily for hospital-based cohorts. And so they've given a lot of money to the coordinating center at NYU to help coordinate and facilitate that. And they have a lot of cohorts of hospital-based COVID patients. And C4R might be joining this effort. Some of the C4R cohorts are probably going to join this effort because we have people who haven't had COVID, as well as people who will get COVID potentially. So we're trying to work through what we're already doing, and they really want us to be involved in this, particularly since we have people from probably underrepresented communities, underserved areas, and people in rural communities as well in this this cohort. So right now we has a lot of acute phase people in this cohort. So that's why they kind of want some of C4R to get infected and uninfected people in this. And they're going to have 3 different tiers of data collection. So it will be the simple physical measurements and blood work and urine and anything that you might, a simple test that you can do even in the home. And then the other tiers would be, you have to go in and maybe get an MRI or get a chest x-ray or some other things like that. And they may repeat that. So C4R is still considering that. But we're also considering continuation of C4R especially for the long COVID. And so that we could repeat some of the testing about especially cognitive functioning and other fatigue and sleep, things like that may be continued. So we're still considering putting in a grant for that. And this just shows you that this was on the press release that was in the Science about looking for the $470 million from NIH to look at that, the long-term symptoms after COVID. But they are going to do something with people who haven't had COVID as well. And then finally, I just wanted to show you again all the cohorts involved and acknowledge the funding from NHLBI, NINDS, and NIA as well. So I think that is it, and I can stop sharing.
That was great, Dr. Howard. Thank you so much. Who has questions for Dr. Howard?
Just out of curiosity, on the serosurvey, there was I can't remember the percentage now, but 5% undetermined. And you said those were ones. What creates that? Were they just unable to be analyzed, or what's that 5% or whatever that number was? What qualifies it as undetermined?
It's a combination of different things. I think some of it is they didn't have enough, and so I think they have to have at least 2 spots on the card, and so and if it was too thin or something, I'm not exactly sure. And I think we have had some participants who said, "Oh, I want to try it again," and so we'll send it back out. And they're really, really curious about it, of course. But for the most part, we've had a pretty good, I can only speak for regards, we've had a pretty good say yes to that, but then I think there are some people we send it to and they change their mind. They say, "Oh, I don't want to do this." I mean, if it's just a finger prick. So, but some people kind of say, "Oh, I don't want to do that." It's not really a big deal, but there are some people who are squeamish and they say no. And then, so we're also trying to wrestle with, do we send them reminders, because sometimes people forget they got their little package. But again, it goes back to that collider bias and some of the different things that we want to do. We want as many people as possible to represent all different types of people who are doing this. So not just the highly educated or the highly, or the lower education or different people in different parts of the country. We want, a lot of different people who have different exposures, people who maybe or don't get out of the house much, or people who have. So it's also interesting the types of questions that are asked. And like they ask about, did you change your behavior? Some of the questions are, did you change your behavior, and how did you change your behavior? So did you, social isolation, for example, is a really important factor in a lot of diseases, especially related to cognitive functioning. And so maybe people didn't see people, they didn't go out and do things, but maybe they changed the way they socialize. So there were people who know how to use Zoom or knew how to be creative and sit in their driveway and talk with their neighbor, and they could be creative. So that's an important thing to see. And it's also important to cover the rural population as well as, the other in big cities type things. So we have a big group, in the big cities, in Los Angeles and in New York and areas like that. So it's important to get, that's what's so exciting about C4R. It's got some great representation all over the country.
Awesome. Thank you.
Hi, Dr. Howard. This is Ruhi. Sorry, can you hear me?
Yes.
Yes, Dr. Howard, I think actually you partially answered my question. How is the representation from rural areas in this C4R study?
I don't think I have. I don't think they've provided that to us in terms of how many we have that. I showed you that map of the target people across the United States, but that it doesn't show how many are in the rural. But that's a good question to ask them to give us that. I don't think it's as many as we would like because of the studies that the cohorts such as Cardia and Eric, who have field centers, who have the clinics, they have to kind of be close to a clinic. And so maybe they're not going to drive in an hour out to come into the big city. Say, if come into Birmingham, if you live in a very rural part of Alabama, and they might not have been approached to join that. So it's probably not as many rural people as we would like of that total 53,000.
Thank you.
Hi, Dr. Howard. I was just curious about, so I got that everything is harmonized from COVID data. Is all the pre-COVID stuff also harmonized across study? Like
Some of it is being harmonized, and some of it is easier to harmonize than others because a lot of times people ask the question the same way. So if you wanted to get something about like hypertension, just does the participant have hypertension? That's pretty harmonized, and the question about do you have diabetes? That's probably harmonized pretty well. Ask, defined a similar way with blood work and the self-report, combination of those. And like a lot of the cohorts use like Cohen's perceived stress. But then there's others, like they're working now on a proposal related to health literacy. And there's different ways to ask to measure that. And so the proposal that they're working on, they're going to have to do kind of their own harmonization. So say if you wanted to write something and you didn't quite know what each cohort had, there is a listing of what each cohort has. And then you can contact somebody from that cohort and say, how did you measure it? Or you can look at, some other things so that you can determine whether or not you'd have to do some harmonization. Because I can tell you the harmonization for the cognitive assessments is very intense and very time consuming because it's being done by telephone or in person, and it was done different ways. So when you're asking questions like about their memory, some of the cohorts might have asked, they ask you to recall these words that I gave you, and some people might wait 3 minutes before asking you to repeat them. And some cohorts might ask you to recall it after 4 minutes. And so there's something to be said for harmonizing that. So you have to have a variable in there to consider, for that as well. But for the standardized things, I think you would be pleased that there's some good harmonization with some common, again, trying to really work with common data elements. And I just will put a plug in for that in all of your research. When you're designing a new study, really look at common data elements in the Phoenix tool, and even for demographics. So when you're asking even about race, ethnicity, and even gender identity, if you can ask it the same way that other cohorts are doing, as we're supposed to do. And, Regards didn't ask it. It was just basically, the simple and, self-report. And you just have to probe a little bit more. So nowadays, we just need to be really careful about how we ask things. And, there's got to be some better standardization so that we can pool these data, because I think there's wonderful opportunities. And I know that NIH loves to see people working together, and like one grant helping another grant, that they love those things. And so even if you're thinking about writing another grant, if you are utilizing some data that another grant already collected, that just makes that grant look that much better, and helps you too, that how smart you are to say, well, I don't have to reinvent the wheel because they did this, and I can take advantage of this kind of things and add something on. So I hope that some of you will try to apply for this. There's going to be these awards, will be here for a little while, but they are anxious, especially if C4R wants to continue. And we do want to submit a continuation, and we're trying to do that for the February. We would like to show how many people were interested in C4R, and how many people wrote papers, and how many junior investigators were able to use that. So I will put a big plug in for that. And also please share this with your colleagues who are not on the call and aren't hearing this, that we can share that as well.
Great. And I would like to send out something via email after this webinar with more specific info, the website again, and info on how they can apply for the $5,000 award, and also details about the call for papers. So that,
that's a great idea.
Something that people can forward to others as well.
That's a great idea.
So in the $5,000 awards, are there deadlines for that?
Well, all you have to do is write a proposal, a manuscript proposal, and it goes through the committee to review. There's not really, they haven't said there's a deadline, but it just takes a little while to go through. Like I said, they wanted to get some done by November. It depends on how many they get, I would imagine. So
great. That sounds good. Good. And then I also see a question from Dr. Azad Bhuyan in the chat, and I can read it for you, Dr. Bhuyan, or if you want to jump in. So the question is, what is the sensitivity of dried blood test?
I think it's really good for what they are giving the participants. It's when they want to dig into it a little bit more that is maybe a little bit more unknown. So if they can just, I think that it's pretty accurate in terms of if they're just telling the participants it's there or it's not there, and I can't tell, that is a good. But now they're trying to do some other things, like define which antibodies they have in terms of which variant, dig into the kinds of antibodies they have. And so they're able to do that, but that's, not a clinical test, just some research tests at this Wadsworth lab that's doing that in New York. They're doing some investigational work, given that, we have some knowledge about when they got a vaccine and which type of vaccines you can do. You can imagine there's some other great research that can be done with that. So I'm not that familiar with it, but I know that they are doing some.
What other questions are there? So, and we are fast approaching the top of the hour. Any other questions? So, oh, let's see, another message. Okay, good. So in the chat, there is also the link to the evaluation that we hope that you will complete for this talk. And then also I had added the website URL for the C4R website with more information there. And then we'll also send out more information about the call for papers as well as award proposals.
The speaker who's coming.
Sorry.
Go
What's
ahead.
that?
Howard, I have one question. Do you know how many people who are end stage kidney disease or liver disease in this cohort?
I'm sorry, I didn't understand the question.
I said, I just wonder how many people with end stage kidney disease or liver disease in this cohort?
Oh, we would not know, but we could get that. That would not be, and you won't find it on in the website either in terms of some background probably, but all the cohorts would have those data in there. I'm almost positive they would all have information on that in their cohort.
Oh, because I'm really interested in this group of patients. Thank you.
That would be great. I have not seen anything about kidney disease in anything that's come up so far in any of the proposals. So, yes, that would be great.
Yeah, I want to write a paper proposal for this.
I would encourage that. I don't see that there's anybody else doing that in all the ones that they've listed so far. So I would really encourage you to do that.
Thank you so much. I will do it.
Great, thank you, Dr. Chu. It's good to hear from you and to see you there too. Okay. Any other questions before we wrap up? Anything else? Okay, then I will once again remind you to complete the evaluation and to also thank you, Dr. Howard, so much for giving this talk. Really important information and exciting that it's come together so quickly during the pandemic to look at the data and what's going on with it. So it's nice to have that information. So, and as you know, this seminar series is co-sponsored by the Deep South RCMAR, the CCTS, the CORE, and the UAB MHRC. And we appreciate everyone attending and look forward to hearing your comments in the evaluation forms. And come again, next November, or next month rather, Thursday, November 4th, we have another speaker and another topic that will be the last webinar of this year. And then we'll start again in February of 2022. We've got a great schedule planned. Okay, anything else, Dr. Howard?
No, I think that's good. It's all good. And I appreciate your interest and commitment to this and being part of this great seminar series.
Great, thanks everyone.
Bye-bye.